best option for pregnant women? Or what you are prescribing?
That's a very good question. In fact, pregnant women, again, pregnant women, these people would have, if they have, you have to find out whether these patients have gestational diabetes mellitus or they have probably pre-diabetic. These parents, both parents are diabetic. These people come as first manifestation of stress hyperglycemia, or they develop gestational diabetes. But later on, these people would develop diabetes mellitus in the long run. But in pregnancy, other than the metformin, we can't use any tablets. So it depends on, again, what is the patient profile. The other day I've seen a lady who's just 26 years old, but she was 93 kgs body weight, and she's got a sugar of 300. There I would not prescribe her metformin for taking care of the sugar. I would definitely go for insulin. Now, again, the next question, so it depends on the profile, how the patient is, whether what's the body weight, what's the sugar level. Third is, I would say you have to be a little individualistic about what would be her acceptance in taking out the self-monitoring sugar. So someone who is well-trained, educated, office-going, or a very intelligent lady, probably it will be very useful to give her self-monitoring of blood sugar instruments, a glucometer, and try to get what's the PP fasting sugars again, and what would be the PP sugar, and you have a telecommunications system. The telecommunication means you have to ask them to give, text them what the sugar is, and give individual doses of everything when it comes at the end of the day. What I do is, I ask the patients and give them that, look, I'm starting with short-acting insulins 3 times a day. I don't start a long-acting one initially. So I give 3 prandial cover first in diabetes, which is again just the opposite of a normal diabetic. Normal diabetic, we usually give a long-acting one, take care of the fasting, and then we take care of the postprandial. Here we do, depending on, if someone comes with 300 sugar before breakfast, of course, you have to go for a long-acting one with the short-acting one for the taking a prandial, the post-meal cover. But if you see the patients is around 200, these people, we start with a 4 or 6 units of insulin. The insulin, again, would depends on what is the profile. If the patients come very affluent people, we can go for analog. If the patient is not affluent, then we go for human mixture. The most important issue is the self-monitoring of sugar is very important, because diabetic patients usually have a lot of insulin resistance. The requirement is quite high. As you know, the placental lactogen and other hormones liberated during the pregnancies always have an anti-insulin effect. So we go and see the self-monitoring. We don't start, just give a 4 unit, otherwise she probably would not be starting it. And at the end of the day, when she gets 3 units, so before dinner, she texts me that my before breakfast is this, my before lunch is this, my before dinner is this. No calling, because if so many patients call you, then you get very sort of disturbed. So if text comes, you can always say from tomorrow, you increase the text one, because the fasting blood sugar, if it's high, then you have to, before the dinner blood sugar, you have to go up. If the before the lunch is high, then you have to, before breakfast has to go up. It's like, covering that up. Taking care of your prandial ones, not giving an hypoglycemia before the next meal. So you go on increasing in such a fashion so that patient doesn't get a pre-meal hypoglycemia. If the patient doesn't get a pre-meal hypoglycemia, then you can always go for a 2 hours meal, which I don't prefer a glucometer, because the glucometer gives a lot of variations with the post-meal, and the machine is not been discovered for postprandial measurements. The machine is been discovered for a nocturnal hypoglycemia, an odd hour hypoglycemia to measure. Now we are using it for self-monitoring. Glucose is fine, so we use it for fasting sugars, before breakfast, before lunch, and before dinner. Postprandial has to come from the laboratory. So if you see that preprandial blood sugar, you cannot go any more up. But still the postprandial sugar is still very high. There, you have to change over to analogs. Because the action is so, I have shown the slides, that it is long acting, requirement is high, absorption is low, so you go for analog. So even the patients cannot afford, for the baby, they would probably like to afford to get a good, healthy baby. So that's my sort of way I handle it. Thank you.